There we go. All right. Good afternoon, everyone. And thank you so much for joining us for the second session of the 2024 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor is the Western New York Rural Area Health Education Center, also a HRSA-funded education center. And this is the 5th year we have been hosting these educational sessions, so thank you so much for your support and for tuning in. My name is Laura Robinson. I'm the program coordinator for the Finger Lakes Geriatric Education Center. My co-host is the lovely Christine Chappell. She is the administrative coordinator at the Western New York Rural AHEC. So we have just a couple housekeeping items before we begin. We are using Zoom meeting today instead of Zoom webinar. That allows a little bit more interaction when we get to the Q&A part. But there are 2 important buttons on your toolbar. First, please use the chat button to type hello, introduce yourself with a name, job title, agency, and location. I am so excited to say that we have people from at least 13 states and 2 countries, well, 3 countries if you count the US, joining us today. And the chat button will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question. We will leave time for questions at the end of the session. The other really important button is your microphone. Please keep it muted throughout the presentation. We are recording, so you can go back and watch this afterwards too. So we have a couple of slides to go through before we begin. Just to let you know, we're offering continuing education credits for this session. We are pleased to offer CME, social work, physical therapy, occupational therapy, and mental health practitioner credits. None of our speakers or planning committee have any financial disclosures or conflicts of interest. We will email you instructions on how to claim your credits immediately following this session. Please allow up to 30 days to receive your credits. We are also going to send you 2 evaluation summaries after this session as well. Diana has one for her organization and we have one for HRSA. So please fill out both. We'd really appreciate your cooperation on that. Also, no commercial funding was received to support this activity. All the funding comes from HRSA. Thank you, our fairy god funder, HRSA. And if you have not already, please register for our next session, which is next month on the 15th. It is Dr. Desai from the University of Washington School of Medicine. He's going to provide guidance on screening and treatment from a primary care physician perspective. So now I will stop sharing my screen and invite Diana to please share her screen while I give you her introduction. So Diana Padilla has worked in the field of behavioral health for more than 24 years. She is the SBIRT, that stands for Screening, Brief Intervention, and Referral to Treatment, Training and Implementation Specialist for the Northeast and Caribbean Addiction Technology Transfer Center. Ms. Padilla has worked with a host of organizational settings to support integration of SBIRT into services to address substance use and related concerns with adolescents, older adults, ethnic and racially diverse, and trans and non-binary communities. Using a culturally responsive and recovery-oriented perspective, Ms. Padilla further instructs on how to enhance strategies and interventions for working with diverse communities. This content typically integrates trauma-informed care, racial stigma, social drivers of health, and affirming and inclusive best practices for clinical, non-clinical, and peer support professionals. So we are very honored and excited to have such an experienced and knowledgeable practitioner with us today. So I will now turn the program over to Diana.
Thank you, Laura. Let me see. That's about, okay, great. Thank you, Laura. And thank you for your support, and Christine. And thank you, everyone, for being here. And I'm just delighted to start to present on this topic. We've been learning a lot lately, and we have seen the importance of having to really broaden our scope when we're doing work and helping the community. So hopefully this will translate in a helpful way for yourselves. So let me just go on to my slides and start here. I have to put this in there. We are funded by SAMHSA, and we have taken an approach to being able to use language in an intentional manner. So we typically have the words have power, people first, language matters slide, and this all speaks to one of the many ways that we can address stigma. And one of the things that is really important, not just with this community, but all communities who are in need, particularly in reference to substance use, is to address stigma in our language. And so very often we have been trained for a long time for different terms and terminology, which I'm going to go over now. But many times the communities themselves have identified stigma as being one of the biggest barriers to accessing care. And so how we align ourselves with them, how we interact with communities and members in need, is really important to really be more intentional these days than we've been in the past about using certain words or certain terms very intentionally in order to reflect that we want to be an ally and partner with community members and to be able to help them maybe walk with them in their wellness process. So we're trying to promote the use of affirming language and culturally and linguistically appropriate ways. And there'll be a little bit more about that as we go forward. And so one of the things that can be helpful, and this has been identified in the more recent 5-6 years of behavioral health, and it has to do with the different terms that we've been trained on and we've been educated on over the years, we've been using in our work and our practices, and really how it has really evolved. And particularly when you think about the DSM-5, there has the terms for the different substance-related situations or conditions that the individuals have, or the diagnosis, have been changed to address the stigma that sometimes we reflect in language, and sometimes what happens is that community members kind of internalize on their side. So it makes sense for us to just do a quick review over these terms. The substance use terms are very specific to levels of use and very specific to perhaps how we address or use certain protocols to help individuals who may have risky levels of substance use or substance use disorders. And so to kind of dispel the idea of having to use substance abuse, which is what we have been educated on for many years, we have evolved our competencies and we are evolving our language opportunities by looking at these terms very specifically. Substance use is a term, and this is all relevant to the content as I'll go through it. Substance use refers to the consumption of psychoactive substances. That's pretty direct. But that substance use is not just opioids. We're talking here, I'm referring to alcohol, I'm referring to legal substances that people use. So tobacco, alcohol, prescription medications, along with illicit substances. Substance misuse is a term that is referring to the inappropriate use of prescription medications. And so substance misuse is not using medications other than how it's prescribed, or perhaps even binge drinking. And so that's another reference to substance misuse that we don't tend to use a lot. Another term that came from folks at the National Institute of Alcohol Abuse and Alcoholism, the NIAAA folks, risky substance use, referring to the consumption levels of certain substances in ways that cause harm or cause hazardous consequences. And so a person can actually consume or indulge at a level where it puts themselves at risk of having some harm done to them. For instance, a person can drink at a level that might actually impair their judgment while driving. It can actually impair their ability to just cross the street and just get off the curb in a safe manner. And so putting themselves at risk of that is a harmful consequence. But hazardous is for folks who are consuming at a level where they're already experiencing some of that. Perhaps there's some health-related issues. Perhaps some of those issues may be impacting their mental health conditions or exacerbating conditions so where they can't achieve a mental health diagnosis. Or it can also, implicate, say, other psychosocial issues, for instance, the relationships, the performance level at school, the performance level at work. And so the level of risky substance use is when folks are indulging at levels that put them at these risky consequences, but not necessarily at a point where they would actually achieve the criteria for a diagnosis for a substance use disorder, which is this last one here. And that's really an 11-point criteria where that actually looks at cognitive, behavioral, and physiological symptoms of related to that chronic level and the severe level of chronic use. And there are many people that we don't necessarily address or look for that are the level of misuse or risky substance use. So it's not just someone with a substance use disorder. A lot of what's going to be covered here is related to a stage before that. If you think about it, the progression of substance use of any kind, whether it's alcohol, whether it's using pills to mitigate any kind of symptoms or any kind of situation, whatever it is possible that people can consume at levels that they don't meet the criteria of substance use disorder. And many of the disciplines tend to address issues when someone is at that level of severity. For our purposes, and particularly in terms of thinking about the aging community, this is what we want to consider. And so in terms of medications, medication is not a bad thing. There are benefits to medications. When there are different medical situations that occur for people in different ages for a variety of different reasons, and medications help a person get better, to recover, to get to a level of homeostasis where it can be very helpful for them. There are certain conditions or certain situations that tend to be age-related. And so with some of the benefits include vaccines to help prevent many infectious diseases, such as the flu, influenza, pneumonia. People over 55 are recommended to have the annual flu shot. Everyone actually is recommended to do that. With folks over 50, between 55 and 65, there's always an extra recommendation to also get the pneumonia injection to have protection. The autoimmune system of the individual, just of like the biological nature of the body after some time, once you get into certain age brackets, it starts to slow down. And so using medications like this, these vaccines, these can be helpful for to help create protection. So antibiotics are effective for treating infections, including pneumonia, drugs to control high blood pressure. Many people do have high blood pressure and have maybe a family history of cardiac arrests, so it helps to prevent strokes and heart attacks. Some folks need prescribed medications to control blood sugar levels. And many individuals who may have a diagnosis of diabetes, this can be extremely important. And so it helps people live more normal lives and be able to have a quality of life despite the challenges, the physiological challenges. And drugs also can control pain, as we know, other symptoms that help many people just to function in their daily life, to be able to mitigate symptoms of pain so they can achieve the daily responsibilities that they need to. And so the body's perceptions of substance misuse with this community, with the aging community, tends to come from it's not always that we think of bias in a negative way. We think sometimes our bias is really looking at people from a positive perspective, and we're thinking that there's certain situations are not related to them. And so the reality is that perceptions of misuse with the aging community can really create barriers for them. So alcohol and substance use disorder tends to be underreported, underdetected, undertreated in older adults. And you could put, since you have access to the chat, please feel free to put your own reasons why you think that is so. Some of the things that the research and the data shows, and some of our experiences working with the other folks in the communities, has a lot to do with that societal perspective of what someone with a substance use problem looks like. And it's not necessarily that beautiful grandparent type of visual that a lot of us get. And sometimes that kind of gets in the way of us even being able to facilitate a substance use screen. And so it may not necessarily, and then a lot of times the symptoms may look very similar to other medical issues. And so there's a variety of reasons why many times substance use disorder goes untreated in older adults. Even though as a population, as a community, the substance use disorder rates are lower in the aging community, is gotten a little higher than what it's been in the last several years. The other thing is that by stigma, stereotypes, ageism has to do with, failing to screen for substance use because it probably wouldn't help at that age, or at that point in their life, maybe, it's better just to leave them alone. There's different perspectives that actually come into into why a provider or professional may not look to screen or to address a particular issue. It's much more common. Illicit drug use is much more common around older adults who have more than it's been in the previous generations. And so what we've seen in the, say, the individuals who fall in the cohort of the baby boomers is that they're more likely than the members of previous generations to use illicit substances. And so it may be that clinicians may think that older adults don't use psychoactive substances. And so there are different information, there's different information and research that's actually telling us different. And I think this is a perspective. The biases that we as providers may include, like, my client doesn't seem to meet the criteria of substance use disorder. And this is off the research and anecdotal comments that have been captured to kind of grab the attitude of what might actually get in the way of screening and helping an individual that would benefit. And so sometimes, like, caregivers and providers and family members misunderstand the differences between symptoms of substance misuse and other medical conditions that are also age-related. So that can certainly fuel a biased perception. And we'll talk about that. So societal norms tend to reinforce the perception that older adults do not have substance use disorders, and that has a lot to do. Think about what do we see on TV? What do we see in the media? What do we tend to see? There is not necessarily a lot of drug problem related visuals that is associated with the older population. And so that kind of speaks to some of the protocols that we might want to consider. Are we screening for substance use universally? If we're not, is that an opportunity to consider? I'll talk about that more as we get to the other part of the presentation. Older adults may not even realize themselves just how much drinking is a problem, or that their medication or substance use intake might be misused. And so the information does not necessarily get to the population. A lot of folks who are, as you get older, many people are conditioned to doing things a certain way or learning to do things a certain way over time. And so not many people are necessarily informed that the physical changes in their bodies may also have a lot to do with how their bodies metabolize different substances. And so if they're not getting that information, whatever they thought in the past was working for them, it may be more likely that they are using the same thinking for that. So it can be difficult to recognize in older adults and lead to maybe like treatment delays. Even a family member or caregiver may not necessarily immediately recognize that substance misuse is taking place. So the inability to discern between those symptoms, and it's what's the very reason why we're having this type of presentation, why these kind of webinars focus on this particular topic is really essential. There are symptoms that, and I'll talk about that in a few seconds, but there are symptoms that actually, they're both physical, cognitive, sometimes psychological, that can actually mimic mental health issues or other medical situations. And depending on our focus as a provider or as a practitioner or as a clinician, whether you're a social worker, a medical provider, whether you're working in prevention, recovery supports, or you're working in addiction, it really depends on your perspective, on the lens that you use for your work, that sometimes we might miss certain cues that can help inform how we can best provide for the older adult. There are things like sometimes dementia, pain, and anxiety and depression can be very specific to certain mental health situations, but sometimes do caregivers, do family members, are we able to discern between that and what, say, depression? Can we discern between one and what it may look like for an individual? Have like 3 or 4 drinks where they start coming down after a rebound effect. And so these are things that can really mimic each other. And so there's other influences that might not necessarily make us think that possibly a substance or an alcohol or a pill or medication might actually be reflecting some of this. So some of the misinterpreted substance use symptoms. So age is associated with degeneration, physical pain. And so exposure to opioid analgesics is just having the accessibility can increase the risk of substance misuse or the disorder. And so risky substance use can seem similar, just very much like I was saying before, similar to other medical conditions, other psychological conditions, even the most natural thing in the world where a lot of folks have sleep apnea or sleep disorders. It can actually come from substance use or substance misuse. And it may seem like the most natural thing in the world that because someone's getting older and they're not having the same amount of sleep or they're having too much sleep, it may be considered the most natural thing because of the age factor that providers may be seeing. And so, but it's not necessarily true. It's really about, it can easily be mistaken by both the caregiver, family member, and even providers. And so some of the things that can be helpful here, maybe, and I thought this might be important to consider, just a kind of review, because we know that as an individual gets older, the body does not work exactly the same way. The biological functions do start to slow down. And so, for instance, like when we think about pharmacokinetics, when we think about how water decreases in the body and fat increases in the body, and there's less muscle mass. And what the consequent effects can be is when a person is prescribed medication or someone takes medications, the effects are not as quick to impact the individual. And so it can also stay in your system longer. The metabolic processes do slow down. The decrease in body water, that's a really important one to consider. When someone, any individual who drinks alcohol needs water, the water in their body is the very thing that's going to help them metabolize that ethanol, the alcohol. And so when the water decreases in the body, the alcohol content can seem to stay longer in the bloodstream. And so the impact can last a little longer. And when you consider that there's more fat and less water, it can certainly be part of the reason why the impact of alcohol or someone can feel tipsy a lot quicker, a lot longer. And then there's also a difference between male bodies and female bodies at birth. And that has a lot to do with not just the water content. There's typically less water content in women, but on females. But there's also less certain enzyme production, which escapes me right now. Certain enzymes do break down alcohol as well. So there's less production of that as well. Decreasing gastrointestinal processes, slower gastric digestion, absorption, and emptying, all that helps to metabolize. All of this is kind of working together. And so when that slows down, gastric issues that a person may show up at the doctor's office or may be experiencing and shares it with a physician to be able to get some treatment options behind it. On our side, it really should help us also think about, well, how do we eliminate alcohol or any other substance use as a potential source of this gastric issues. And a lot of times in the medical field, or if you're a social worker, one of the things or addiction counselor, one of the things you can think of is like, okay, at a certain age, the metabolic processes do slow down. And so there may be an issue of maybe too much aspirin, or maybe an issue of what they ate, or because the digestive process slows down. But it's not necessarily thinking about how the substance use may have an impact on this. And so that's what I'm trying to help encourage all of us to kind of think about how we broaden our perspective in our lens in terms of our practices and working with folks who may have some of these challenging issues. So levels of albumin tend to decrease, and that's particularly important in terms of being able to kind of move different medications throughout the body. The decrease in liver function, which is needed to metabolize anything that anybody injects, and particularly harsh with certain chemicals from certain medications. The decrease in kidney function. So these are the different things. So it may take longer to excrete sometimes the medication is into the urine, and so it stays long in the body. And so all of these simultaneously working to different degrees can certainly create slower processes, longer acting impact of medications or medications and alcohol and whatever other substance. And so these things kind of are age related. This is not necessarily the information that different people get. So, Laura, would you please?
I'll be 68 in March. I've had a beer or two every night since I was in my mid-30s. Never had a problem until a few months ago. Lately, when I drink my beer, I feel a little tipsy. My son says I'm slurring my words. What's going on?
Thank you. And so that is just, that was a comment that was captured in one of Sam's surveys working with the aging community, which really reflects, the lack of information or lack of education in terms of how the physiological changes occur during different age stages in an individual. And so when they don't necessarily get that information and they're still keeping the same habits they've always had for a long time, we know about conditioning, and many of us are conditioned to doing things a certain way, whether it is how much we drink, what we take for any kind of pain, how we deal with different situations. There's no reason to change if we don't have information that will indicate otherwise. And so this is just one individual who's not aware of some of the changes that happens physiologically that I just went through. And so what it ends up happening is there is a certain amount of concern within the community. 25% of older adults, when we think about it, because of the medical issues that do occur that are related to the age, folks are actually prescribed prescription medications. And these medications do have the potential to be misused. There's a couple of different factors that are going on here. There's the point that there's accessibility. There's also an experience of relief from pain. There's also the opportunity that when certain stresses and situations occur in an individual's life, that might be a coping opportunity. And so concerns regarding the misuse of medications alone and the combination of alcohol medication misuse has been estimated to affect almost 20% of older Americans. And so here I'm going to ask you a question. If you can respond in your chat box, thinking about the medications in the community, almost 90% of older adults regularly take at least one prescription medication. Almost 8% regularly take at least 2 prescription medications. And what percentage regularly take at least 5 different prescription medications? What are the numbers? What do you think? 5 prescription medications. Well, you know what? And well, those are really good numbers. Actually, they're more on the side, on the high number side. The number that I had for here, thank you, everyone. I have 36%, but just recently, and this is based off of one study, just recently as last week, I was reading this other research project that actually indicated over 50%, 50 to 55%, which is really incredible, but not surprising. So thank you all for your responses, but not surprising, because the idea here is that just having that many prescription medications increases risk. But that's just imagine having to take 5 prescription medications, on a regular basis, and how interestingly challenging that can be for that individual. And so the opportunities for misuse do exist up to extreme level for aging community. So one study has showed that 3,000 adults aged from 57 to 85, not only have prescription medicines, but they also take non-prescribed medicines, dietary supplements, over-the-counter medications. Patients from 50 and on were about 25% who misuse prescription opioids or benzodiazepines. Unfortunately, what comes with that, they express suicidal ideation. That's a quarter of them. And we have, and I forgot the numbers, I forgot the most recent numbers, but the age cohort that is that's over 65 is the largest cohort we've ever had in the history of the United States. And so we're talking about a lot of folks here. So all the way from 1999 to 2019, almost 80,000 Americans age 55 or older had died due to an opioid overdose. And there's a lot of different situations that kind of come into play there. So alcohol in the last year, and I know our focuses have been a lot on opioid overdoses, and that is appropriate. I don't want to dismiss the fact that every year for the last many years, alcohol-related deaths have occurred at the same high rates, like more than 100,000 per year for, I don't know, for the last maybe 10, 12 years. And so, and that is something we don't always think about, the high propensity, the high risk for this community to overconsume with alcohol. So here what we have is among these folks up to 80 years old who drink alcohol, 1 in 4 report having 6 or more drinks on at least one occasion. And the current recommended guidelines, according to the dietary supplements, which is sponsored and recommended by the National Institute on Alcohol Abuse and Alcoholism, state that the appropriate drinking guidelines is 1 drink per day for healthy-bodied females, not to exceed 7 in a week, and no more than 2 drinks, and people over 65. And then no more than 2 drinks a day, not to exceed 14 in a week for healthy-bodied males. And so when you think about that, and you have this many people who are drinking 6 or more drinks at one occasion, huge risk to health, huge risk to injury, huge risk to their medical and physical outcomes. So 7% said alcohol had made it difficult for them to remember parts of the day, and we know that to be the blackouts. 1 in 10 adults said they drank while using other substances. So the polysubstance use is it can be just as prevalent with some individuals in this community as well as any other community. So marijuana, prescription tranquilizers, sleeping pills, pain pills, and even illicit substances. And even before cannabis was actually legalized for recreational use, and even for medicinal properties, it did provide opportunities for individuals to be able to mitigate certain health conditions, certain pain that they have, considering maybe a limited income. It did provide an opportunity for being able to address certain health issues. Unfortunately, it also increases the risk for potential substance use disorder. And so there are folks who might have health issues like alcohol-induced dementia. And dementia, we think about it as an age issue, but it can be alcohol related. The cirrhosis of the liver, we kind of tend to think about that. Sometimes when there's stomach or intestinal bleeding and thinking about perhaps an existing digestive issue with a particular person. And again, it goes back to like, are we even screening for the alcohol and potential impact? So the recommended guidelines is what I was saying before, is 1 per day, not to exceed 7 per week for a cisgender woman or a person over 65 years of age, 2 drinks per day, not to exceed 14 a drink for a person with, for a cisgender man. Here's the interesting fact. So unless we know this, and unless we convey this to the community, how would they know? Then the liquor bottles do not come with these recommended guidelines. So that is, how often do the communities that we provide services to actually get this information? It's not necessarily posted everywhere, and it's not some common knowledge, is what I'm saying. So let's think about the effects of substance use. So in terms of when is moderate drinking like still too much for an individual, even if they follow the guidelines, even if you was aware and you're able to convey this information for individuals? How about you folks put it in the chat box? When is moderate drinking, or even taking the drinking recommended drinking guidelines, even then, when is that too much? Add your comments. When it interferes with daily activities? Yes. And what else? Very good. Yes, don't drink and drive. When it interferes with chronic conditions, when you're already impaired. Oh, yeah, when individuals are taking the medications, that's exactly right. And here's the thing, even over-the-counter medications can be a contraindication of drinking. And so driving, taking meds, affects physical activities. Yeah, If the individual is even aware of changes with their age, of how they metabolize, that can be really helpful. And then I'm understanding there are situations where, you know what, even one drink may be too much, may be inappropriate, not healthy for them. So thank you so much. That's great. So I have very much of what you folks put up. So medications that interact with alcohol, um, medical conditions that can be worsened by drinking. There are certain medical conditions that can have that can actually cause more of a negative outcome with alcohol. There are some folks who are recovering from alcohol use disorder. So of course that would be, if somebody's recovering from alcohol use disorder, that diagnosis right there, drinking at all can actually lead them back and, having a relapse or recurrence. So planning to drive a car, and you folks mentioned this as well, or participate in activities that requires alertness and skill. So for instance, let's just say, so that individuals may be caretaking another individual. Many times what we find is that one individual, yes, the caregiving, one individual may be of age where they are actually caregiving for their partner. And they may be amongst, in that older age bracket. And so there are different situations like that where caring for oneself, really requires including, can I have a drink? Is this something, can I actually socialize? What's the environment I'm socializing in? Do I have a means to get home? Is this a time where it's okay to go after work out and then still be able to accomplish certain things or take oneself home and those types of situations. And so this is not always the type of conversation that we have in our practices, particularly when we're talking about the clinical protocols that we engage in, but it will certainly inform them if we actually get insight as to this. And so we're going to talk about that in a bit, about how to engage someone. So thank you for that. Yes, another co-occurring condition. Conditions that worsen with alcohol use include the stroke, having high blood pressure, osteoporosis, memory loss. Like I said, memory loss is like sometimes it's an age degeneration issue, but it's exacerbated when a drink or two can actually also further impact with blackouts. So diabetes gets worse, ulcers get worse, mood disorders get worse, and sometimes, and I mentioned before, depression, where someone feels, sometimes someone maybe doesn't have a diagnosis of depression, but may have an episodic depression experience, and maybe folks who kind of feel that way may want to take a drink or two to feel elated. And if a person stops there, that might be appropriate. I don't recommend feeling any kind of way and then and having alcohol use, but this is kind of a Western culture thing, that when you are tired or when you have a challenging situation, that you kind of, relax with a drink or two. Unfortunately, what happens is a lot of times is when a person thinks, well, if a drink or two makes me feel relaxed, I might have a third or fourth drink. That third or fourth drink may actually exacerbate situations. If somebody can actually come down, stress the biological functions in the body that much more, and mentally, the person can actually, the alcohol actually becomes a depressant, and mentally an individual can actually kind of crash. And that biphasic response from alcohol, going over the threshold more than what they need at any given moment. And a lot of people don't have that information. And so dangers of mixing medications is even thinking about aspirin in a drink. A lot of people don't think that it would have any type of reaction because it's not a psychoactive substance. Well, aspirin in drinks can actually exacerbate gastric issues and actually initiate intestinal bleeding. When combined with alcohol and allergy medicines, it can help somebody feel sleepy. That can be extremely challenging when someone has not able to control their level of alertness. And so the antihistamines just exacerbate, the impact of the alcohol. And so large doses of acetaminophen can cause liver damage, cough syrups, laxatives, particularly those with alcohol. If they're not reading labels, it's a good habit to have. Using alcohol with sleeping pills on antidepressant can be lethal. So triggers that exacerbate substance use, we gotta also consider some other things. being for that individual in that stage of life under situations such life stressors, whether it's trauma or some financial. They have a bunch of there are a lot of different types of situations that can stress someone to a point that they would want to have a drink or want to have a relief of some kind. So that includes retirement, a change in perhaps someone who's been working most of their life, and that's part of their independence, and they've had to stop, or they've had to step back from it, maybe not because they're at an age to do so, but maybe because they had to, because they no longer are in position or in the capacity to perform at the level that is required for the profession that they had. And I think many of us can understand, but more in particular, an older person, the death of a family member or someone close or someone dear or a pet can be extremely impactful in a different way for someone who may be at an age where they're considering their mortality. The lack of having perhaps a purpose. Even Samson has the 8 dimensions of wellness, and we talk about, how having a sense of purpose, to something to engage in, some kind of common cause, it's very helpful for individuals feeling they're valued and not get caught up in a depression, and that can lead to using substances. And so relocation, trouble sleeping, family conflict, mental and physical health decline, all of these can actually create situations where the person may increase their risk to substance use. So medication misuse can include the mixing of prescription medications, as you folks have mentioned it. It also is when taking several doses of the same medication or when not needed. So sometimes failing to fill a prescription or forgetting to take medication. Sometimes it may be not taking and not forgetting to take medication, but trying to stretch how long they have a medication. And so not taking it appropriately or as it's directed can be misused, and it can be for a variety of reasons. It could be that the co-payment is kind of strict. Is a bit of a strain financially. And so to make it last longer, it's better for them. Unfortunately, they're not necessarily taking the appropriate dosage for their medical condition. So it's a variety of different reasons. Folks are not necessarily intentionally trying to, let me just misuse this because I want to get high. That's not necessarily the first thought. What's happening here with a lot of individuals, particularly in the older community, is they're trying to navigate through their world to the best of their ability, and sometimes with misinformation or lack of information. So stretching out medications or discontinuing earlier than directed, not adhering to dosage instructions, using medications, and here is really, really hard, is when someone is using medications intentionally to cause themselves harm or to actually to get a high. So but there is interesting that some surveys that have come out that have identified that many people, if they could, if their doctor was all right with it, they would love to not take so many medications. Up to 80% who are willing to stop taking one or more medications if their medical provider has said it was possible. Unfortunately, many people, if they stop it, what happens is their medical conditions are exacerbated. So 26% have stopped taking at least one medication over the previous year on their own. So not taking medications as prescribed, those missed doses can have an impact on an individual, including the higher risk of being hospitalized behind their situation, the medical conditions, not getting the appropriate treatment, appropriate care. So 25% of hospital admissions among 65%, much people who are 65 or older, are due to inappropriate adherence to medications. 25% is a huge number when we're talking about this cohort. And so identifying and addressing substance use, because I'm looking at the time and I just want to make sure that I cover this. When we think about the different things that are going on in a person's life and just in general, our perspective is one that's made up of so many different factors and influences and responsibilities and goals and more and more and more. If we think about for ourselves that those different factors, we can also consider for any given individual, particularly an individual who's over 65, what are the different factors and realities of that person's world, to be able to understand reasons of why they or their capacities to be able to help manage and navigate through their daily world. And so we covered quite a bit of some of the influencing factors, both protective but at risk factors. And I'm also thinking about how they can get support from the caregiver who may or may not be aware of some of these physiological changes, some of these dynamics that may be happening in the person's life that might actually increase the risk of dealing with some of the situations with substance use and how to recognize that. And so just so we're clear, so today's folks, and this comes from a 2023 survey, today's snapshot of the older adults, there are a lot of folks are still working in 60, 65, and 70. They're a lot more energetic, and people are still doing a lot of things. It's a different type of perspective that even I grew up as a kid and how I saw older folks. I would tell you that 1 out of every 65-year-olds today live past 90, and folks are living longer, and 1 out of 10 will live past 95. In 2021, there were almost 56 million adults in the US, and which is almost 189,000 more than in 2020. And those numbers, certainly, we're in 2024 now. And we really should tap into the numbers from late 2022 and 2023. Up to 4 million are estimated of the adults in the US identify as gender diverse or transgender, either lesbian, gay, bisexual, transgender, or, non-binary or queer. So there's a lot of folks with different living sexual identities, gender identities, sexual orientations, and different dynamics of their world impact their decision-making process. Nearly 10% of older adults who do live in poverty. Older women are twice as likely to be living in poverty as older men. Racially and ethnically diverse older adults are more likely to be poor than white older adults. So we see some of the social determinants of health kind of fluid in here somewhere. And so really understanding that the dynamics of any given person's life is really helpful to understand in order for you, so it can help inform your practice in terms of how you're supporting them. So because this is the snapshot of older adults in today's world, we want to be able to try to distinguish between misuse and disorder. Most older adults who misuse substances don't meet the criteria of DSM-5 for substance use disorder. And also, I probably should mention that the DSM-5 criteria was not necessarily designed with older adults in mind. The physiological changes, the different dynamics in terms of the physical and cognitive conditions are different than your average older adult. And so providers can engage older adults in illness management and provide education, on misuse and health and wellness. There are different strategies out here that can be so helpful. It just helps us. It helps us when we're informed to be able to convey that information. So there are a lot of changes that do come with age. Are we familiar enough with some of those to be able to convey that with individuals and learn from them how changes in their life have occurred, so we can help inform. So the age-related physiological changes can help older adults reduce barriers to substance use, and also help us in our perspective to understand that we could actually facilitate substance use screening more universally. So the idea is for us to use a person-centered approach to address and intervene for risky substance use, and not to make assumptions that they automatically are not using substances and they probably wouldn't benefit from any type of support. And the idea is to be able to individualize care. So patient-centered approach is critical. So SBIRT is, Laura mentioned in my introduction, screening, brief intervention, referral treatment. So I refer to it as SBIRT, and it is an evidence-based model that was used with adults in the medical field. It's proven evidence-based there, and it's the best practice with different populations. So screening, brief intervention, referral treatment is a comprehensive public health approach used to identify and intervene with individuals very early on regarding their alcohol or other substance use. Particularly, it's really designed to help identify those folks who are consuming at levels that are at risk. It's not looking to identify the person with substance use disorder. There are already evidence-based protocols for that, but it doesn't leave those folks with that likelihood out. Screening, brief intervention, referral treatment is a process that helps identify these folks and helps the provider, helps the practitioner to be able to have a collaborative conversation with the individual, with MI at the heart of it, just to inform the individual, and perhaps they can actually be motivated to understand and maybe want to change their behavior so they can be, in a healthier way. So the primary goal is to identify and effectively intervene with those who are moderate or high risk for psychosocial or medical health problems related to their level of substance use. And so there are three components: the universal screening, which is exactly what is recommended. The brief intervention, which is as a whole dialogue, is a conversation to build awareness and hopefully lead to folks thinking about their reasons why they probably think they should change, deal with situations differently. And the referral treatment is really just a referral for further assessment when needed. And so some of the screening tools, Laura, you can let me know how much time I have and when I should pass it over. And
right.
chat box.
You've got about 9 minutes left, but we don't have any questions in chat yet. So I'd say keep going.
All right. So thank you for that. So I wanted to show you folks some of the substance use screening tools specifically designed for the aging population. We're not using dumbed down versions for instance, like when I was saying about the DSM-5 and the criteria for substance use disorder was specifically designed, but it wasn't including the age, the 65 or over physiological changing type of community issues that tend to occur. It's not necessarily using that. So what we see here is a validated instrument, the Senior Alcohol Misuse Indicator, or the SAMI tool. Here's the interesting things that I've seen, and I've worked with many organizations to help them to provide technical assistance and capacity building supports to be able to incorporate expert in their settings. And what I found is that many times we will have a screening tool in our intake process, in our admission process, but we don't necessarily have an interpretation for it. We ask the questions and we continue to other questions. And yet we lose the opportunity when we have these screening tools are designed, or they're developed very specifically to identify a potential issue. If there's an issue to explore, we can do that with this. So there should be an interpretation or scoring mechanism. And so our scoring component. The SAMI tool is made for this this community. The short mass geriatric version also has, it's just 10 questions. So one of the things that you want to keep in mind that with this population, you need to these validated instruments need to be prefaced. You should set the stage, so to speak, create the atmosphere, make sure that you're affirming and culturally appropriate. The atmosphere is comfortable and then the individual feels safe enough so you can engage them in a conversation and ask if you can ask these questions. In order for these questions for this tool to work appropriately, you would need to ask these questions verbatim. And so set the stage and build that rapport with the individual. And if you get permission to be able to ask these questions, ask them very specifically. And this should give you a score. So here you see 2 or more yes responses indicate an alcohol problem. And so what you want to do is, if there is a problem, and if the screening tool indicates a problem, then you have the opportunity to engage. You have the justification actually to engage in a conversation. And so the assist light actually works very similarly. And so the questions are really for the past 3 months. And so what you're doing here, again, asking questions verbatim before you even ask the questions, prefaces, set the stage, ask permission, initiate a rapport with the individual, and then ask the questions, and hopefully they will respond as transparently as they can. And so the assist light interpretation also indicates either low risk, moderate risk, high risk. My concern sometimes is when I work with organizations and that have their screening tools, but don't have the interpretation. Otherwise, there wouldn't be a point to even asking these questions. These questions can't actually identify potential issues to explore. So the screening score can give you an idea of the risk level that the person might actually be misusing certain substances. And so what you want to do is have a conversation. The conversation that I refer to is a brief intervention. And that tends to be the second component of the expert evidence-based model. But the brief intervention was already a standalone evidence-based process. When it is used with the motivational interviewing spirit and communication skills in the heart of it, it can really prove to be so effective in terms of helping to increase that individual's awareness about risky substance use. And so substance use behavior is not your traditional, well, substance use, someone's injecting, they need treatment. I'm referring to here where someone may be misusing those pills or may be misusing and using alcohol on a day where they are taking medication or they're socializing and not necessarily having a conversation, being informed about the potential impact on their health and their daily functioning. And a lot of you folks were talking about their daily activities. So the BI is a short conversation that helps increase that awareness of risky substance use behaviors. And it's a way of providing information, eliciting feedback from them and asking, they're at the center of it. This is a person-centered approach. And so it's a way to actually increase their motivation and perhaps give advice when it's elicited, when it's asked for. The idea is it's totally is directed by the individual and work with what they share with us. And with the motivational interviewing practice, and I'm talking about the 4th edition, not the first one we learned many, many years ago in the late 90s. And this has been revised by the developers, William Miller and Stephen Rowland. Just last summer, they came out with a 2023 publication. The main core communication skills were actually enhanced and updated in 2013. And so it has really become such an effective practice. And in terms of expert, it's a required component. And so it's just a way of being able to engage someone in a conversation where it feels like they're not being judged, where they feel like we're very much allied with them and in supporting them where they're at and giving them education, tidbits of information where it's digestible within a conversation and they can just repeat it back, and maybe that can lead to a potentially to a different way of addressing certain situations they may be misusing substance use behind. And so MI is a person-centered, evidence-based, goal-oriented method for enhancing that intrinsic motivation to change by exploring and resolving ambivalence and helping the individual come up with their own reasons for why they want to change. So there's an amazing way of doing that. It's a really great way of doing that by just having that collaborative conversation. And so what I suggest is, first of all, there's expert and there's also the standalone components, but that is the best way to help get insight into the individual's world and what's working for them, and help inform as to healthy options in dealing with the different life stressors and understanding the do's and don'ts of medication, adherence, and medication intake. So let me ask you, folks, I'm kind of down to I believe, my last slide. So these are some resources I want to provide you. I like that. So Paul has put in there, there's this Lifespan has offered an in-home intervention program for older adults who misuse substances. There's a recovery and wellness for older adults in Monroe and Livingston counties. Harm reduction approaches is key here. The idea here is for us to first think open-minded in a way where not to make assumptions that this community may not be dealing with certain substance use. And that can certainly lead you to all these opportunities and how to engage the community and help them. And there are some other resources that I provided here. And I believe you will be getting the slides. Are there any questions that you would like, did you have in mind that you would like to ask? Please feel free to ask.
All right. Thank you so much, Diana. I did not see any questions come into the chat yet, but folks may be just clapping right now, and so they should be typing. I did put a link to your survey in the chat. Also, you can use the QR
Good.
code that's on the screen right now. This would help Diane out immensely. They do count this towards some of the data they record for SAMHSA for that funding. So there will be 2 surveys for today's session. So I appreciate everyone taking a few minutes to take those surveys. We now have some thank yous coming in, and thank you, Paul, for the referral to Lifespans program. It's been around for over 20 years. So while we're waiting, Diana, I do have one question for you. I was thinking about BIPOC communities and how just the trust is not always there. And you say to have a conversation with them, and I know that's the start, but is there anything that you have found in your experience that has worked well with BIPOC communities in order to kind of change the mindset, shift the mindset a little bit towards, okay, maybe I do need a little assistance with this substance that I've been using?
I think it's critical. It's critical to culturally frame any of our practices. And this is highly highly probable, particularly when you're trying to do like screening and brief intervention, because those things you have to do, those questions you have to facilitate verbatim. But you still, before you do anything, to have a conversation of a very intimate subject, then you want to be a culturally informed environment. Use your pronouns when you introduce yourself. Have actually ask the individual how they would like to be addressed. Ensure that you don't make assumptions about language. So for folks, it's really the brief intervention helps when you start to preface it as soon as you meet them, and making sure that they're comfortable enough and feel safe enough and think that you are open enough for them to be responsive to the questions that you may be asking them. And so that is something that is very the non-judgmental. The respect means integrating their perspective to asking them about what a day in their life looks like and what does, what are their challenges may be. And it's not about us dictating to them. It's really about us eliciting that information and listening more so they can tell us. Based on what they tell us, we can follow that to help support them right where they're at.
Okay. Well, thank you, Diana, so much for this presentation. We truly appreciate your expertise. We've gotten a lot of thank yous now in the chat. I want to let everyone know I will email out Diana's slides to you. We will email out the links to the evaluation surveys. And again, if you have not signed up for next month's talk, meet us back here on March 15th for Dr. Desai. And Diana, if we get any questions, I will share your email with everyone. They'll be in the slides as well, and
Yes,
we'll send
please.
you the questions.
Thank
All
you.
right.
And thanks everyone for being here.
Thanks, everyone. I know we're over time a little bit,
Thank
but we
you.
will see you next time.
Thank
Bye.
you.